I came to the retreat in the fall of 2007, so like August 2007. For my first internship, I went to Antioch in Keene for clinical mental health counseling, and you have to do 2 internships as part of your master's program. And I talked with one of the professors there, and he said, "You want to go to the Brattleboro retreat?" What drew me to the internship was wanting to understand addiction and wanting to understand recovery, and what that meant beyond just somebody can't stop using a substance and it has this effect. And I was like, well, how do you use language and behavior to help people change their emotional and spiritual well-being? People know or have a family member or addicted to some form of drug or alcohol. So it really touches everybody's lives, whether people admit it or not, realize it or not. A lot of people, I think, who are addicted don't know they're addicted. A lot of people socially look at addiction and then just say, what, he just drinks a lot. I now know what that means in a different way. I think we need more education within our medical schools about proper prescribing practices. I think we need more education within our medical training system, within our medical facilities, within individual practices around addiction medicine and around what addiction is. Albany Medical School has had medical students doing rounds of residencies here over the last 2 years, which has been awesome. That means like the next wave of doctors is getting exposed, because no matter, and these are people that are just in school, they're not necessarily sure where their specialty is going to be. And the reality is they're going to be interfacing with people who are addicted to substances, so they kind of need to know what it looks like and how to help understand it and how to help people with it so that they're not contributing to the problem. Around what responsible and healthy prescribing looks like. And I also think there needs to be better education about, for somebody who is addicted and has surgery, what proper prescribing looks like. Because the reality is when somebody's addicted, their tolerance is so high that an opioid dose that might provide you or I with pain relief won't touch the pain of somebody who's used heroin or opiates for years. And it will look like they're just saying, give me some more drugs, but they're actually in pain. So I think there needs to be education on both sides of it. There needs to be education about what does safe and responsible prescribing look like to begin with? What does over-prescribing look like? And it needs to be clear that managing chronic pain with opiates is never a good idea. The treatment facilities are kind of overrun with opioid addiction. Not that the others don't exist, but because of the intensity of the substance, addiction can happen faster and people can kind of go downhill more quickly. The potential is there than with, say, alcohol or cocaine or marijuana. It's like there's a problem that will start. Pharmaceuticals are attractive to people who are using because it's a known quantity. I'm going to get an Oxy 80, or I'm going to get a Percocet 30, a Perc 30, or whatever it might be. They know that it's that dose, and they know it came from a pharmacy of some kind, a pharmaceutical company, whether it's a pill mill from overseas or in our own country, or a legitimate one that just ended up on the street. It's a known quantity, it's safe, it's not cut with anything, and I know I'm going to get the same thing every time. When you get a bag of heroin, you never know what it's going to be. It could kill you. It could be, weak. It could be anything in between. It's a less sure thing. It's insidious the way it happens. I don't know if you've seen The Hungry Heart. I encourage you to see it if you haven't. It's a really good pictorial. It's a documentary about a heroin addiction in Vermont. And nobody wakes up one morning and says, "Mommy, I'm going to grow up and be a heroin addict." It happens. It's not because anybody wants to have it happen. So our people are sick. We are sick and need help. The Department of Health and the Department of Alcohol and Drug Abuse Programs got together and said, we need to figure this thing out because we're getting sicker quicker every day. And so some lovely, brilliant people at the state level got together and talked about a system of care. So they've created a hub and spoke model. This is my job. I supervise our hub and spoke. Our hubs are daily dispensed clinics We dispense Suboxone here at the retreat. Habit Opco dispenses methadone. We're the only like co-hub in the state in southeastern Vermont. The other hubs, they dispense both methadone and Suboxone at the same site. They might have more than one site, but both sites will provide Suboxone and methadone. There are 5 hubs across the state and 7 sites. And then there's spokes. The hub is a daily dispense clinic. You show up, you take medicine that day, you leave. You go to group therapy, you meet with your counselor, and you come every day and you get your medicine. And eventually you might be able to get to take homes depending on the medication and the hub and their rules. The spokes are prescription programs, so it might be in a primary care doctor's office, might be in a psychiatrist's office, might be here at the retreat. So the prescription program allows for a lower impact on somebody's life. They can show up once a week and eventually get to every other week and eventually get to once a month and get a prescription for a week or 2 weeks or a month so that they don't have to be here every single day. It's hard to get someplace every day. The fact that we need to do something so our people stop dying